Welcome to Crosstalk. The Social Health Authority, SHA, was launched with bold promises to give every Kenyan access to affordable healthcare, to fix what NHIF broke, and to finally make universal health coverage a reality. But here is the question. SHA was meant to replace NHIF failures. Has it solved them or simply rebranded those failures? 26 million Kenyans are registered, yet millions still don't know what exactly their contributions guarantee. Health facilities speak of delayed payments, and patients still walk out with bills they cannot afford. This is the conversation we want to have today. Healthcare. It is a constitutional right, not a privilege. So who ideally is SHA really working for? The government, hospitals, or you, the Kenyan citizen? That's the question. You can join me on this conversation through our SMS line 20316. Our WhatsApp line is 0786316316. In studio with me is a panel of great minds. These are the best that we could get for this kind of conversation, to offer a sober perspective to what is happening in the Kenyan state of healthcare. Joining me on set now is Madam Caroline Kwamboka. Welcome.
Thank you.
She's an international development and policy and advocacy expert with over 23 years of experience advancing sexual and reproductive health and rights. So we have the best person that we can bring on this particular conversation to look at both local and international practices when it comes to healthcare. Also with me on set is Job Karuna, who is accomplished emergency nurse, health strategist, and digital health advocate. Welcome, sir.
Thank you so much.
It's amazing that we are talking about SHA and it's a digital operated platform.
Exactly.
Karibu.
Asante sana.
Also with me is a set of panel from different spheres of our economy and sectors in our country. We will be coming to you for your views on this particular topic. But let me start with you, Madam Caroline. When you look at our health system as a nation, how would you rate it?
The state of health in our country is wanting. It is wanting for two main reasons. One, the burden of disease is really a challenge to the citizens, to the families, to the communities. And on the other hand, the means of meeting that burden of disease is also limited. So on one hand, a lot of disease. On the other hand, limited resources. And this really requires a very sober conversation because at some point, it has to give. Something has to give for us to restore the balance and strive towards having a healthy population that can be productive, not one that is burdened with ill and limitations of resources.
Job, your perspective?
Thank you so much for having me and for everyone who has joined us today. Healthcare in our nation is in a crisis, and a dire one. Most of us who had the privilege of being in the urban center and maybe having access to private care. But for people in the rural area, in the arid and semi-arid areas, if you go there, your heart is going to sink because there's limited access to healthcare. Facilities are fast stretched, and whatever is available is thinned and overburdened. Carol has just mentioned the burden of disease. Currently, we are seeing a rise of various conditions that some of them never existed before. Think of oncology cases, think of emergency care that is all over. What is it that the government is doing? Do they have structures? Are there policies? And is there the goodwill to implement the actions that they keep on saying on the rallies? But also to think it from a professional perspective. There has been a training that is happening in our universities. We are seeing that every year there's rollout of medical doctors, as nurses, every year. But the question, when you go to the hospital, you're not seeing the doctors, you're not seeing the nurses. So what is happening to the human resource in our country? The other thing is what is happening to the capitation that is being allocated to every county from the national government? Where are these resources? We can't see them. So at the end of the day, the healthcare remains to be a crisis, and sadly, the one who is bearing the burden is the citizen.
It's the citizen.
So this is an urgent call for all of us to act into our positions and to step up into our roles.
Caroline, why would we have that kind of disparity? What is the gap, if you look at it?
Actually, if we think about it in a very structural way, we need to reflect on these challenges based on the health system building blocks, as they are called academically, but really, let us simply put it that for a health system to work, certain things all have to be in place and in balance. Okay? We've really had excellent input here, reflecting on human resources for health. That is a key pillar. We need the service delivery or the point of service delivery to be in existence. We need diagnostics, and there is definitely a great representation on the factor of diagnostics, the laboratory, and then we need medication. You need the medicines that are to intervene should there be a case that requires treatment to that extent. And then we cannot forget the governance and the financing that is a key factor that moves the health system. It is the oil that really has to come in for the wheel to move. And even though the traditional way of looking at the health systems was based on 6 pillars, I always like to say there is really the community. A lot of the challenges and the issues that are happening within the health system have affected the community, but also the solutions are also in the community. So these things all have to come into play, into concert for the solution to be found.
All right. Let me bring in Robert. In terms of our systematic problems that we experience in our health sector, is this a political will to make things work, or it's just purely a governance system that has failed to make things roll?
You know, the health sector in Kenya is a very critical sector. But if you look at the way the governance structure of the health system, it is very wanting, and that's why we have a problem in the health sector. And we have systemic problems because, firstly, this comes from the incompetence among those who are those who have entrusted with the, leading the health sector for us. And another thing is that our health sector is so much business oriented than, providing health services to Kenyans. You can imagine that SHA, which is only 1 year old, it was launched in October last year, has got a debt of 36 billion as we speak right now.
Yeah, and
so you can see the business interest in it too much.
Okay, and we'll be coming to that as I come also to just get some comments as well. But Job, from where you sit, that transition from NHIF to SHA, what has that done in the health sector?
The transition itself, I think we should first ask ourselves, was it necessary? Was it that NHIF was not... is it that NHIF was not working or performing up to our standards or up to our expectations? And if that was happening, was there a need to roll out a new program or just to work on improving whatever we have? Because to a large extent, NHIF was working. Immediately after the rollout of SHA, we could see old men in Nakuru moving from one facility to another facility, saying that they are seeking dialysis services. And every facility they went, they were told, we are not accepting SHA. This is someone who has been on dialysis close to 4 or 5 years, and now you're telling them you can't access dialysis. So where do you want this person to go? So definitely that's a gap. And and just to say it bluntly and bold enough, that SHA was not needed. What we needed to do it is to improve the systems that we had in NHIF. If there were gap holes, if there were fraud loopholes within the NHIF, why can't we work on them? If it was about the infrastructure that supported SHA, if it was about the personnel, these are key questions that we should have considered and asked ourselves, and maybe even looked around and to see what other countries or what other nations are doing, because bringing a cost, 104 billion cost, and you have a debt of 30 million, make it sense.
Caroline, if you look at that, as I said in my introduction, we have 26 million Kenyans who have registered for this. But if you look at the number of people that are paying the premium, it's roughly around 4 million. So it seems like 4.5 million Kenyans are carrying the burden of a system that is failing them.
Kenya, like most countries we have on the continent, even in our region, has a very interesting demographic arrangement whereby more than half the population, in fact, going into almost 60 or 70%, are really below 35 years. They are young. And when you interrogate that cluster, that largest cluster of the population, they are not in productive economy, not so much. Which brings the number even down for those who are paying naturally, because the multiplicity of deprivation is a reality. You know, not having a job means you cannot afford to pay the premium. Let us start there. And if that is the issue, you can be registered but fail to pay the premium. And the minority that have to hold the rest of the population, okay, then have an excess burden, because let us say the truth, it is not only the SHA payments that are being experienced by the minority. How many groups do we belong to now in our society, in our community, in our churches, in our bunge, in our schools, in our universities, Madam upcoming MCA? How many people are knocking on your door asking for an emergency intervention because a child is sick or a mother is sick? And when we look at the life cycle, where is the heaviest burden? The young, the mothers, the children. And these are the ones who are not part of the productive economy. So when we look at it that way, and I think Job has put it very well, you realize that the burden is only getting worse. And the issue of addressing health financing and how we are going to manage this SHA is actually a matter of urgency.
Pastor, I want to bring you in. When you have someone whose child is sick, I doubt if their focus will be on the abbreviation of NHIF or SHA. What I want is to get access to medical care for my child who is sick. So if we have an economy that is not sustaining that, to allow someone to access that medical care and pay for it, then why pomp and color that this system is working?
Yes, those are realities as a pastor. I actually just had one case where a child of a member was born with a condition on the eye, and so they needed to go through an operation. The brother is a very active one, but when he needed our help, we had so many things. So wondering, how do we balance this, because these growing churches? So luckily, SHA worked for him. He paid, I think the cost was around 140 something thousand. SHA paid around 78,000. So that's a good thing. However, after investigating, somebody said the amount he pays monthly, they should be able to pay the whole thing. I'm not sure about that, but that's what I heard. So that's a reality, and the truth is, nobody will be interested with the name NHIF or SHA. It is about working. And from where I see it, it is the issue of leadership, what my friend here was saying, because everything rises and falls on leadership. I don't think in Kenya the problem is the society per se or the community. I find most of the time the leadership is the issue. And as a leader, it is not my work to give excuses. It's my work to find solutions and guide people, because you cannot lead people where you have not been.
Purity, are these some of the things that you experience on the ground as we interact with people?
Today morning, I even shared with Madam. I sent just a message somewhere in a certain WhatsApp group, which has more than 1,000 members, and I asked them, is SHA working or is it not working? So I need to hear from you people if there is anyone who has an experience. And I got 2 responses. One told me that SHA is a scam. It is not working. The second person told me SHA is working. SHA paid for me 85,000 yesterday at Kenyatta National Hospital. And this person had paid only 6,000. So if you compare the 6,000 and 280, let me just be, yes, to almost close to 300,000 paid by SHA. That is someone who appreciates that it's working. The other one who went to the hospital, they were sent back to them, it's not working, it is a scam. Now here is my contribution, what I think, because SHA is an insurance, okay? Being an insurance, for you to get to receive the benefits of what you have contributed, it means it's a pool of risk where same people with the same kind of risk, you make your contributions. I give my 500, you give yours, everyone give their 500. Now, there are Kenyans here who don't contribute at all. They have not been contributing. Some don't have money, genuinely. Others have, but they feel like no one is pushing me. After all, I'm not employed. I'm a business person, so I don't need it right now. So those people who don't contribute, it means in the near future, there will be nothing to give back to the hospitals. Because if you don't contribute, you just wait until you have someone sick and you give 6,000. Then after treatment, you don't contribute. We are definitely going to have problems as a nation.
Okay.
Thank you.
Let me bring you in a job from a frontline experience. What do we need to do then?
Good, thank you. As she was speaking, she mentioned about SHA being an insurance. And that's the setting that that SHA has been founded on. But when we started the episode, we started by saying that health is a constitutional right. So for SHA, yes, there's the contribution everyone is making, but is it not the government roles to take care of its own people? Because if you tell me it's an insurance, that means if I can't pay, then I do not deserve access to it. So what is going to happen to me? We mentioned that only out of the 26 million people, only 4 million people are paying. Do we understand that 22 million people are not paying? And what is it costing? Have we done a root cause analysis to dissect and to explore the reasons why these people cannot make to pay for SHA? Those are some of the questions that the government should be thinking of. The other thing is the over-reliance of SHA as the only driver or financier of healthcare in the country is going to leave this country and its citizens exposed to everything. So it is a call and it falls directly within the mandate for the government to cater for its citizen. Yes, SHA is there, but apart from SHA, everybody is paying tax. Where is this money going to? And apart from even the tax that we are paying, there's a pool that every employer and every employee is remitting to SHA. Where is this money going to? As of August, we had a lot of money that SHA had not remitted to these hospitals. These hospitals need to run. They need to get medications, they need to pay for their operational cost, and they also have a payroll to maintain. The other thing is we need a strong governance. Remember, SHA, as it is for now, to many it is just a paper promise. That I have SHA, I'll go to the hospital, I'll be rejected. We saw a lady in Naivasha the other day going to the hospital for an excision of tumor, and they were told, your tumor has not reached this extent, so you can't access surgery. I mean, what do you want? You want them to get more sick so that they can access health care? And right now we are talking about the burden of NCDs, the non-communicable diseases, where these kind of conditions fall under. And they are the burden that they form the largest percentage of conditions that are in the hospitals. So it is a call for us to have a strong governance to start with, to have the right structure. Then with those insights, we will know how to run the healthcare in the healthcare sector in the country, not only SHA, because SHA is just a sub-segment of the whole system. Yes.
Okay. Caroline, is this system unique to only Kenya, or we can borrow from other countries?
A very, very interesting question. Actually, the SHA system as it exists now is not only in Kenya. The difference is that in some other countries, the way community insurance scheme was developed, for example, Rwanda, was a bit different. It was a bit different because it came from the community insurance perspective before it reached social health insurance system. In a place like Tanzania, they have a tiered system so that for a certain level of contribution, you have access maybe to level 1 and 2. In Ghana, we also have another system where they have a chief's camp. They call it chief's camp. And there, all the primary healthcare needs that anybody needs on a day-to-day is covered. So, and very efficiently, so that you don't wait to be extremely sick, as you know, the example that you shared, for you to reach a point of care. And even as we are talking about this, let us also reflect on what preventative health has in store as to what else we can do to really have a healthier society that is not overburdening the health system that can hardly meet the needs of the day-to-day, population, or rather the needs of the population on a day-to-day basis.
Okay, I think we'll come back to answer that question after a break. But Joe, before we get to that break, is this system like a good house with a leaking roof?
Definitely it is. If we can look back to the intention that SHA had, it was supposed to work, but is it working? So it calls for a lot to be done. Of course, it's a new product, but it's a new product because we threw away what we had, and we never even asked ourselves, why are we throwing NHIF? But also as citizens and also as communities, we have a role to take care of ourselves, and the government can also step in by ensuring that there are enough community-led community workers who are going to educate the community and just lead them in everything.
Okay,
yes.
Thank you. We want to take a short break, but when we come back, Robert and the team, currently, DCI is probing 31 facilities with almost, in fact, over 691 million fraud cases. It looks like we are a rich country. It's only that we can't get our acts right. That's a conversation. I'll come and get your views on that as well. Maybe it's working for you, like Purity has mentioned. Did a survey, to 1,000 people, at least one worked for them, one not. Maybe share your comments. You've used the Social Health Authority and you've accessed medical care. You can share your experience on 20316, which is our SMS line. WhatsApp line is 0786 316 316. We'll be back after this short break.
We are living in a lost and broken world, constantly bombarded by messages of hate and atrocities. But with God, we can overcome. Find hope and restoration on the go through life-changing shows on the Family Media app.
And then you will lose yourself and gain the world. And Jesus said, what good is it?
Get to stream Family TV and Family Radio 316 straight from your phone. Catch up on a show you missed or create video streaming playlists by saving and watching videos from our huge variety of shows at your own convenience. Download the Family Media app, available for all Android and iOS users on the Google Play Store and Apple Store respectively. Family Media, keeping Jesus on the airwaves.
Welcome back to Crosstalk. We are looking at the state of our healthcare system, and in focus is SHA. I have a great lineup of guests who are giving their perspective in terms of what they feel our state of healthcare system is. Joining us now, also on this set, is Nicholas Odipo. He's the chairperson of Kenya National Union of Medical Laboratory Officers. I want to give him an opportunity just to introduce himself, but also just in out of 10, how would he rate our healthcare system? Welcome, sir.
Just as you have mentioned, I'm Odipo Nicholas. I'm the national chairman, Kenya National Union of Medical Lab Officers. Medical lab officers are the cadre of healthcare workers who do diagnosis in hospital setup. Talking about the status of health, I don't want to rate it low, I don't want to rate it high. But in terms of service that the healthcare workers are supposed to be given, we have a well-trained health workforce in the Republic. The only problem that we have is the kind of policies that are being brought into the system, because in every workplace, it has to be driven by the policies that the government brings. So when the policies are not aligned to the vision of the healthcare workers, then most definitely there will be some instability in the healthcare system. So in terms of the quality of health workforce, we can give it around 8 out of 10. In terms of the injection and investment and policies, we can do it at around 5.5 out of 10. And speaking about SHA, the experience of SHA is out there. The citizens themselves are talking about SHA. Despite the fact that the owners of SHA, or the government, is trying to be all over the place, trying to tell us that this thing is working, this thing is good. It can be good, yes, but has the citizen felt its goodness? That is the main question that we need to ask ourselves. Yeah, because it can be good, but the end user, are they feeling it? Okay. That's the question that we need to ask ourselves. Right. Thank you.
Thank you. Nicholas, you want to have a contribution?
Yes. Thank you so much, JP, for this contribution. And for me, I believe that with SHA, or the status of our healthcare in our country, is that there is a syndrome called oppositional defiant syndrome, whereby we tend to oppose everything without giving a solution of anything. So I think we as a country, we are criticizing so much this system, but we are not offering any solution which will help in our healthcare system to progress. For me, I believe that the reality is that we cannot go back to NHIF. Now we have SHA. What are the challenges in SHA? And how can we sort these challenges that SHA is facing? Were there falsification of all documents in our hospitals? Yet it was there. Was there conversion of outpatient to inpatients? It was there. Was there the issues of giving fabricated documents of the patients in NHIF, yes, as SHA tried to gap that problem, it has tried. So I think we should focus so much on giving solutions, like advising the government to ensure that more healthcare workers are employed under any terms, but they ensure that the ratios of the patient to nurse, patient to doctor is actually reduced.
All right.
Yeah.
We'll get to that. I'll come to the two of you. Odipo, you wanted to make a reaction? Yes. Please do. Then we can pass the mic.
I just want to make a reaction to
what Nicholas,
my namesake, has said. Nicholas, there's nobody opposing anything in the Republic. Whatever we want is that the systems that are being made, number one, they must be understandable. People have to understand it, including that old lady back in the village. We pinpointed as unions some of the challenges that this thing would pose if it is implemented the way it was. The then cabinet secretary said that the bill during that time will have to pass without a comma being changed. And the moment the MPs passed that bill, she was again there celebrating that I thank the parliament for passing these bills without changing a comma. So if you are telling me that Odipo is now supposed to support something that I corrected and the correction that I made were not factored in, then you might be lying to me. Yeah? So nobody is opposing. Let us just build systems that we can understand. The SHA was not supposed to be for the elites in Nairobi. It is for everybody in the Republic of Kenya. Just a few weeks ago, it was all over. That SHA is paying ghost hospitals. And it is pilferating the few resources that Kenyans are contributing into this system. Now let me tell you, when they were doing the regulations about how the benefits of NHIF, the SHIF, yeah, there was somewhere that they give 900 shillings as a reimbursement for an outpatient in the level 2 and level 3 hospitals. 900 shillings. I am telling you right now, because I work in the health sector, I believe that some of you also do work in the health sector. If you go to the hospital, buying a card will cost you around 50 or 100 shillings. You will be remaining with 800. You'll see the doctor or the clinician, and then you'll be sent to the lab. 2 or 3 tests will cost around 600. You are remaining with 300. 300, tell me which kind of drug you are going to buy with 300. And we complained, we told them, no, look here, gentlemen, 900 is too little. Even back in the villages, it is too little. You want to give quality health care as per Article 43? Increase this amount to around 2,500 or 3,000. So that when somebody goes to the hospital, you are not going to be told to go back to your pocket. Because SHA was supposed to bring equality and also ease the burden in hospital bills.
We'll come to that as we give the solutions that he's pushing, but I want to come back to my guest up here. So I want to hear from you.
I'd like to say that SHA is a new reform, and every new reform meets its resistance, and of course it has some issues that should be sorted, and it's very important for education to reach out to the masses. I would say the fact that is 85% of visits to hospitals are usually outpatient and primary. That is at primary healthcare level, and SHA covers that. It covers for those who are registered. Previously, NHIF used to cover for those who have paid up to its premiums. That is one example of where I'd say at policy level it has really worked. And another point is at emergency, chronic and critical illness fund. For example, ambulance services at NHIF, you'd say that you'd pay out of pocket if you get those services. But for SHA, no matter your status, that is registration, or you have not paid up, you get those services. That is, you get ambulance services. That is at that level. So it is working at some stages, but of course, there's some issues to be sorted out.
Okay.
Yeah.
Different views, and I think this is an emotive issue, depending on which side you stand. So I'll come back to you, Caroline. I'll come to you, Robert, after this as well. Caroline, there's the aspect of this system was made to ideally serve the common person. It was the mama mboga, the juakali, the boda rider. So we were decentralizing health, and it is a devolved system. So why is it that the money is not following the function, and the national government wants to hold on to it?
That's a very good question that is even leading us to one of the things that we need to pay attention to as citizens, and a dialogue that we would like to have with our leaders. The centrality of collecting the fund is or rather the fund is centralized. The activity of collecting or collating all the resources is centralized. The services, as per the Constitution of the Republic of Kenya, are decentralized, except for the specialized one, of course, which have to follow a referral channel. One of the things we really need to interrogate and have dialogue with our leaders, because it's citizens and leaders, we are in this together. We need to really synchronize the scheme of work between where the money is and where the treatment is taking place, because they are not in the same place. And this is really a big issue. You can see the counties coming in time and again, expressing a lot of distaste and a lot of frustration, especially with even the service providers. The ones who are providing the service not having access to the resources they need yet. There has been an allocation made somewhere, and there has been a collection of resources somewhere. So this is one of the things we really need to unpack and resolve. And the other thing that we really need to pay attention to is also the fact that the policies are not negotiated at home alone. These are policies that are going way, way back. We can trace back health even to the 1949 declarations of human rights. And then we come to 1978 with the Alma Ata Declaration saying health must be a right. But let's come quickly now to 2019. 2019, all the presidents of the entire globe meet and sign the Universal Health Coverage Declaration, yet another political declaration that is saying that our citizens will not or should not experience financial hardship. But when you look around, and I will not answer that question, are our citizens experiencing financial hardship or not? And that is the fact that we need to address. For as long as our citizens are experiencing financial hardship in pursuit of medical care, then we have not arrived to the destination that we desire. And we need to address that urgently so that we can get to that one, because that is what the UHC declaration of 2019 says, without financial hardship. So that is the emphasis I would like to make, that the matter of resolving the issue requires dialogue between the citizens. Let the citizens feel free to express what they are going through. Let the service providers express their frustration, and let us get to a point of resolving and reconciling where the resources are and where the resource needs to be.
Okay, thank you. You've listened to what the panel here say, but even as you speak to some of the reactions that have been presented, from the digital front, how comes that SHA still is exposed to corruption to a level of 690 million shillings?
Loopholes always exist, to start with, and some of them are man-made. Some are just deliberate actions that people in place or people leading the digital sector or the infrastructure allow them to happen. Because every now and then there's supposed to be a regular audit to see, is our system working? Where are this money going to? And also, when we are talking about the fraud cases that are happening, and we are seeing that most of them are happening to ghost hospitals, is there a provider onboarding audit that is being happening? Because you will not going to take all the hospitals that are registered in the country and put them in the new system, or everyone who brings in their submission, you directly enroll them to the SHA as a provider. As a SHA administrator, you need to go to the ground, you need to assess the facility. If they are saying that they are able to offer cesarean section, do they have even the right personnel? Do we have gyners in place? Do they even have a theater? So to that will be the first thing to do. Provider onboarding audit. You go there, you do your own audit, and the audit must be transparent, must be honest. A recent report by EACC, we saw that the Ministry of Health is among the top 3 ministries in the country that are leading in corruption. That speaks something in the country. So within the SHA, when you're bringing on providers, you need to do a thorough investigation and a thorough audit for their infrastructure, to the personnel that are there, and to verify that whatever they say they can do, it is indeed true. I mean, we are living in an era of innovation and AI, and we have other countries are already doing it. We need a robust adaptation of technology to help verify the patient. If I say I am Kimani, or if I say my name is whoever, there's need for me to verify who I am. We have seen use of fingerprints, which is helping, but beyond that, what else can we do to ensure that is happening, to ensure that the right person seeking the service is the person deserving to seek that service, you know? So that is just on the digital frontier, but also there's a lot that needs to be happen. We need adaptation of EHR systems all across all hospitals in the country, so that if I'm seen today in Kilifi and I go to Nyanza, I go to Kisumu, they can pull my record. And that is also going to streamline healthcare within our country, and also it's going to leave a trail that is verifiable and credible, that even any money that is paid can be said this was paid for this for this procedure because this patient is diabetic, they deserve this, or this patient is diabetic and they deserve a refill. So these are common, simple issues, but they can help to root out the fraud cases that we are seeing all over SHAM. Yes, and just to respond to a few statements that I have had, and some of them I must say they are a bit sad to hear them. One of us said that anyone who is registered to SHA, they can access healthcare. I don't know if that's the case if I ask Odipo, because on my case it is not true. Even if I'm registered to SHA and I tell the hospital attendant who is on the front desk I'm registered to SHA, they will tell you sometimes you cannot access the services. So it is untrue. That statement, to be honest, is untrue. Not everybody who is registered. We are just from stating that 26 million people are registered. But are they accessing that healthcare? When we talk about universal health coverage, one of the pillars of universal health coverage was accessibility. Is that accessibility existing?
I think Odipo will answer that question as I come. I just want to get from Robert and then Pastor, then I'll come to you. Then as we come back, it's more in terms of, we've talked about there's a destination we need to get to. How do we get to that destination? And I think that's the point where we'll speak to how best can we make the citizenry live alternative health decisions that they can make.
Thank you, JP. I would like to say that health matters in this country are not taken very seriously. SHA was hyped as a revolutionary idea It was hyped as a revolution in the health sector. That is why people are disappointed and frustrated, because it has not made any big difference. I can tell you, JP, I used to be in WhatsApp groups 2 or 3 per week of people seeking, to pay their bills in hospitals. It has not changed for me. Right now, I'm in 2 WhatsApp groups of people who want to pay their medical health bills. So I think SHA has not changed so much. And I want to echo the sentiments of Job here. He put it very well that health is a right. In fact, it is a birthright, healthcare. Access to health must not be pegged on a premium. It must not. That is unconstitutional. And when my sister here says that people should pay, I think she's addressing people who stay in Nairobi. You cannot go in a village, in a remote village in Vihiga where I come from, and tell those people to pay. People who cannot see a single shilling in a month. So health is a right in our Constitution, Article 43. It is an unalienable right, and it must not be pegged on a premium. Okay. That should be very clear.
Pegged as a political promise, because that's what we do with the health system.
Let me finish by saying we are discussing the funding shortfalls of SHA. The funding shortfalls. And right now you can see, as we have said here, 26 million people have enrolled. Only 4.1 million are paying. That one represents only 15% of the people. So it does not make any difference. And that is a very huge funding shortfall. Very huge funding shortfall, which must be addressed. Okay. It is because we did not carry forward any lessons from the previous NHIF. And my brother here, Nick, said that some of us oppose everything and we do not provide solutions. We have solutions. We already have solutions. But can the government, first of all, acknowledge that SHA is not working? So that we can, people go around saying it is working, it is working. Do we need to be reminded that it is working, if it is working? Can Safaricom go around telling people that M-Pesa is working?
That's a good one. Let Pastor come in. I think let's get Odipo's feedback first, then I'll come back to you, Nicholas. Okay. Yeah.
Okay. He said something, and then I asked, who advises the government? Because they gave an advice, and it seems they never listened. Because, as I said, everything rises and falls on leadership. One of the greatest things a leader can learn is actually to listen. Because you don't know everything. The truth is that you may think you are an expert, but you don't know everything. When I was coming to this show, the person who invited me, I told them, I'm not an expert in these matters, but I live in Kenya. I might say something that may help. So I feel like we have so many advisors. I'm not becoming political. But what are they doing? Are they listening? Are they obeying the issue, or are they taking seriously the advice they are getting? The issue of corruption in this nation is such a major issue. The leadership of this nation is a reflection of who we are as Kenyans. That's something that we don't like accepting, but it's the truth. It's just like a church. A church is a reflection of the society. So sometimes people are demanding perfection in church. Then I remind them, you are the church. You are the church. All of us, when we come together, we are the church. So it's the same thing. And therefore, it is a time we need to get very serious about corruption, not just in terms of punishment, but maybe the experts may be here and tell us, maybe we need to begin to inculcate these things all the way from how we bring up children, maybe in the school, maybe in the curriculum, then put very stringent law and make sure that is implemented. As we are going to break, I was talking to my brother here, and I said, this nation has more than enough laws, have more than enough policies. We don't have goodwill of the political class. to implement what we want in this nation.
That's a powerful one. Let's hear from Odipo in terms of not everyone that has registered would have access to this healthcare.
Thank you very much. Now, not everyone who is a registered and SHA member gets the service. And I'll give you an example of me. Some 2 days ago, I had a sick daughter and I went to the hospital. I'm a member of SHA and I contribute 2.75% of my salary. It is not just salary, gross salary. And if you understand gross salary, it is everything lumped together, then deducted. We've had challenges of counties remitting the deducted money. So it is in arrears. I was told you cannot access. My Q, this is something that has been deducted from my salary. Yeah, it has been deducted. It is only remittance that is remaining. And let me tell you one thing. Last year, we were in a meeting and we were discussing this issue of non-remittance of the deducted SHA money and the employees. They told us that they were going to give a room for the employees to be accessing the services, and then they will compel the employers to be remitting that money. It has not happened 1 year down the line. So if I'm here talking about that this thing is not working, I'm talking from a point of know-how because I've experienced it firsthand. And we were there when it started. And we saw those loopholes and told them, no, we cannot do this. Actually, the previous issue with NHIF, and especially on the civil servants, it was that the civil servants were supposed to get a comprehensive medical cover. Then we have a tendency of this in this country whereby those people working in the county governments are not classified as civil servants. They are classified as individual contributors. Actually, what I'm remitting, they classify me with that person, the boda guy, who is also remitting the same. So if my fund is not remitted and the same boda guy is not remitted, we are in the same group. And you cannot complain about it. Yeah? And we told them, no, you see, let us look at the employers who are not remitting the funds. It has been deducted. If something has been deducted through your payslip, allow that person to get the service, because eventually that money will reach to you. But they refused. Wow. Yeah? Now, I also wanted to talk about something, and especially what you've talked about on the issue of ghost hospitals, that they have accessed the SHA portal. There's something right now we actually in a tug of war with the ministry. They are coming up with a certain bill. And they are saying that that bill is now going to cure the issue of the ghost hospitals or a patient not getting the quality services that are supposed to be there. We have compared that bill and what we have already. It is a reflection. It is just a mirror, so that they are changing some few things. Yeah. So they told us that, you see, this one is now the silver bullet that is going to help patient access quality services. We have told them, no, it is not. You are actually just copy-pasting what is here and putting it here, and it has not worked. And currently, what we have can work. It's only that nobody wants to implement.
So it's more of a goodwill.
Yeah, nobody wants to implement. Because if you do implement that, you are not going to have something here dipping your finger. Yeah? So they say, no, this one is not working. Let us bring another one. Bring another one. they want to give more power to the private sector in terms of in giving healthcare services and leaving the public sector. Once they leave the public sector, what about the bulk of the population who cannot go to the private hospitals? That is what we've been asking them. And they are so adamant. They have said that, even recently we were told, I know the corridors of parliament and this bill has to pass.
Wow. Sad reality, and I think this is a conversation that cannot end in one city.
Yes.
I want to get to your closing remarks. We had talked about a destination that we need to get to, and I want you to speak to it as an alternative means that we can be a healthy society.
Yeah, I think I'll bring 3 points to the table for purposes of today, because this conversation has to go on. The first thing we need to really think seriously about is preventative health and how we can maximize opportunities to really have a healthy society. And I know this is, it's not just a cliche, it is dependent on nutrition, it is dependent on access to safe water and safe sanitation services and other public health factors that are required to really bring that healthy society to become a reality. That is one. The second thing we really need to think about is how else can our health system be funded? Can we explore alternative ways, alternative streams of financing our health system? Because the over-dependence on citizens' remittance, to the extent that Nicholas is sharing here, and many others in the room, including Job, is that the dependency is on your payslip, and your payslip, if it is not remitted, then you still don't access the service. And we really need to ask, is this really the only way to fund our system? What else can we do? And my final point is really back to accountability. It's not an easy society we live in, but we are blessed to be really having the opportunity to discuss. We can dialogue. We can find our leaders. We know that they are in our communities and in our societies. And we really thank even the in-between leadership that we enjoy from Bunge, because Bunge la Mwananchi is also a mechanism of getting to our leaders. Let us maximize opportunities for accountability, because these are accrued to us by constitution, by right, but we have to practicalize the same so that something can move. And if we, when I look around the room, I think we've been around for quite some time, and really, there's been worse times in this country. I think we can really get to a better place with the kind of determination that brought us from where we came from. Yeah. Really, we can get to a good place. And this is where I want to, submit to you and really thank you for the excellent conversation.
Thank you so much, Job. As you give your parting shots, also maybe touch something about brain drain, because we also have young people who are expecting to join your industry very soon.
Thank you so much, JP. Healthcare remains a non-negotiable in this country. We should not be having discussions about cash flow and coverage. It is a right that every citizen of this country should be accorded to at any time and at any place they are going to be in this within the corners of this nation. So issues of SHA, issues of how much we are paying, issues of remittance to counties and to facilities, those are issues we should not even have discussions about. They should be automatic actions that the government should be doing. The issue of talking and not doing, we need the action. Kiberenge, my brother, has just said that you'll not see a company going all over advertising and telling people they are doing. What they do as they say. So the government is made up by people. Everyone should be accountable, transparent, and full of integrity in every role they have been placed in. If we are talking about matters about healthcare, you can imagine you are a mother, you have just given birth, and maybe sepsis is seeping in, and yet you cannot access healthcare. Kenya, if we look right now at the maternal mortality, it is still high. It is maybe the highest within the region we are in right now, and yet we have SHA, and yet we have a government. Why are we still experiencing these actions, these situations in our country? Kenya, we are boasting ourselves as a destination of innovation and as an innovation and technology. So that should roll out in every sector, healthcare being the first one. Let us ensure that healthcare personnel is, we have enough workforce. The ratios should at least match. Every year we are having graduates, we are having students graduating with medical degrees, with nursing degrees, with lab, but where are they going to? Some of them are diverting into other nations because we are being told there is no job, and if I have to get a job with a certain county or with the national government, I must give a kickback. Raising my school fees enough was a struggle. We had to involve the whole village. Now you want me to also to go back and involve the whole village for me to get a job? No, that should not happen. We are in an era where God is calling us to be honest and to be good stewards of what we have. And if that is what is God calling us to be, then let that translate into actions that we are seeing daily, actions that are being implemented with goodwill. Healthcare should not be weaponized. Healthcare is a right, and so it should remain that way. Thank you so much.
Thank you. Thank you so much, Job. Thank you so much, Caroline, for your time and insights on this program. This conversation cannot end. This one is an open conversation that we are leaving for next time, and maybe our next conversation we should bring in the CEO of SHA. So then we also get to hear from them in terms of just how they are trying to manage this system with the contribution that is coming from practitioners and from Kenyans. But one thing that has come out very strongly, we need to talk the talk, but walk the talk. Until next time, bye-bye for now.